Should I start?
5, 4, 3, 2, 1, live, sir.
Hi, good morning, friends. Good to see you again in such large numbers, and that too on a Sunday morning. I welcome you all. For those who did not attend the last session, I'm Dr. Agarwal, publishing GP Clinics, which is a CME journal for family physicians. It is being published every month for the last 12 years. Today, it's our second webinar in the series on cough, a distress to a patient and a challenge to a doctor. The first one was last month on fever, a friend or foe, as you all know. And there is no worry for those who could not attend the last session, as a recording is available on our website, www.gpclinics.in. And a session summary with Q&A has been published in the August issue of GP Clinics, which is being sent complimentary to all those who had given their addresses at docislive.com platform. I would like to have two things to clarify here. One, many doctors have asked, is taking GP Clinic subscription necessary to attend this webinar series? So the answer is no. Please note that our objective is primarily to spread education to empower your practice, and there is no compulsion whatsoever. This webinar series is free of cost, completely, and taking subscription to GP Clinics is purely your choice. Secondly, many people have faced some problems in logging in. So our IT team has suggested that there is no problem as such from their end. Nevertheless, they have advised to log in typing https colon and docislive.com instead of www.docislive.com or plain docislive.com. So preferably you type https, right? And preferably from laptop and desktop, you try to log in instead of mobile. If still no success, you may just visit our website, gpclinics.in, and click on the ticker running there, which will take you to the webinar page. Now, again, the format of the program is the same. That is an interactive case-based discussion to approach common symptoms to enable you to make OPD bedside diagnosis. So today will be an interactive session as last time, but in a better way, that a ticker will run for 15 to 20 seconds, and then you have to click your choices A, B, C, D, and then a bar chart will come which Dr. Amdekar will explain. After this, again, the session summary with Q&A will be published in the next issue of GP Clinics. We hope this interaction webinar will make learning interesting to help empower your practice. Regarding speaker, as you all know, those who have not attended the last session, the speaker is Dr. YK Amdekar, and will be the same for all 12 webinars throughout the year. Dr. Amdekar is a practicing pediatrician for the last 50 years and is currently a visiting consultant to SRCCHospital, Mumbai. He has been the faculty to Grand Medical College, JJ Group of Hospitals, and Institute of Child Health. He has been the past president of IAP as well. So here we have Dr. Amdekar once again with us, who will enlighten us today on cough, a distress to a patient and a challenge to a doctor. Over to you, Dr. Amdekar, sir.
Thank you, Dr. Agarwal, for this introduction. And good morning, friends. I'm sure you all know that when a child comes with fever, you are worried, parents are worried. But when a child comes with cough, it's often not an emergency, but a tremendous distress to the patient and a real challenge to you and me to exactly decide how to relieve his discomfort and how to take care of his cough. And hence today, we have this discussion on cough, which is a distress to a patient, but a challenge to a doctor. Can I have the first slide, please? So now you know that, as usual, last time, we are going to have an interactive session. And to begin with, I would like to give you the basic concepts to remind you how we are going to use those basic concepts to discuss very pertinent, common clinical situation that you and me would always face in routine practice, and learn how to be rationally deciding how to go about it. The next slide, please. Now, back to the basics is our principle always. And I think the first thing that you need to do is when a patient comes and says, I have a cold or cough, please confirm what he means by that. Both these terms are very loosely used by the parents and often misunderstood. And therefore, make sure that cold refers to a nasal discharge or a blocked nose, while the cough is a sound that comes out of a forceful exhalation or the expiration. So please ask the parents to clarify this term. I've seen time and again that when the parents come with a history of cold and cough, often there is neither cold nor cough. And please confirm this before you further take the issue to discuss it. Now, once you know it is a cough, which, as I said, is a forceful expulsion that leads to a sound like, so the coughs can be of various types, but make sure that if cough is the predominant symptom, that's the major complaint of a patient, then the anatomical site of the disease is the airway and not the lung parenchyma or not the pleura or not the interstitium. This is the first principle. So always ask the parents whether the cough is a major predominant symptom. If it is so, then you know it's an airway disease. And the next question is it a dry cough or a wet cough? A dry cough comes, as you all know, from an upper airway, right from the nasopharynx to the trachea. And the wet cough indicates anything down from bronchi way down. This is the first difference between upper and lower airway. Please make a note that wet cough may also be often complained by parents or the child as a noisy chest. Many times the child cannot expectorate, and therefore the parents may say nothing comes out of a cough episode. But the fact that there is some noisy or vibrations felt inside the chest, you know that it's a wet cough. However, in an older child, he can expectorate easily. Moment you have the wet cough, which is coming from a lower airway, you like to know whether there is also a tachypnea. And if the cough is much more predominant, but tachypnea is much less, it is a proximal lower airway, which means the bronchi. But if the tachypnea is more than a cough, then it's possibly a distal lower airway, which is what we call it as the bronchioles. What I mean is, in bronchiolitis, the cough is less than the tachypnea, whereas in bronchitis, the cough is more than the tachypnea. This is the way you can define where is the anatomy of this cough. Now, if the cough is not a predominant symptom, but there are other symptoms like fever, you can have a pneumonia, that's a typical lung parenchymal disease, or you can have a chest pain, which is like a pleural disease, or you can have just a mild breathlessness, as in an interstitial lung disease. What have we learned by this? As the site of the disease goes from the airway distally right into the smaller bronchioles and the lung and the pleura, the cough intensity goes on diminishing and the other symptoms start coming up again. So friend, this is the way to define the anatomy of the disease. But don't forget that cough may not necessarily coming from a primary respiratory disease. So the next slide, please. This is the slide for your interaction. And I want you to answer this question, think properly. As I said, the cough may not come only from a respiratory system. Find out whether the cough may be a symptom of the disease of upper GI, eardrum. It could be psychogenic or it could be all of the above. Your time starts now. Good. Let's see now what is the outcome of this. I am so happy and surprised and amazed to know how you all are grasping so correctly. Okay, let me get you to the next slide to show you how most of you have answered so correctly. When it comes to upper GI, a few of you said also upper GI, you are right. Because upper GI, especially a gastroesophageal reflux, okay, coming from varieties of reasons, or aspiration because of a neurological disorder, could also cause an airway irritation and a cough. Remember, all these conditions are going through the respiratory tract, but the primary disease lies somewhere away from the respiratory tract. What about the eardrum? Rarely, not commonly, but if the eardrum is irritated, like a foreign body sitting very close to the eardrum, you may also have a cough as a symptom. And this is because a common nerve pathway between glossopharyngeal nerve supplying the eardrum as well as the airway. And then, of course, it could be psychogenic also. So friends, you know, besides these systems, you also have a commonly a cardiac condition which presents with cough, and also neurological disorders which have often some disturbance in swallowing that cause aspiration. I'm extremely happy, and I know that all of you have started thinking so rightly. Let's go to the next slide now. Now, the next slide shows, next slide, please. Next slide, please. Yes. Now, as usual, I always talk about how systematically we must think. Anatomy first, and if possible, microanatomy. We discussed on the first slide how a significant cough is an airway, and as the airway goes down into the smaller bronchioles and the lung parenchyma and the pleura, the cough becomes less and less of intensity, and other symptoms come further up. That means now you know how to define microanatomy of a cough. What about pathology? Most of them are inflammatory, and some of them could be non-inflammatory, like mechanical cause, inhaled foreign body, or a tumor in the mediastinum, which is compressing the airway from outside, or a muscle spasm itself, like in an asthma, where the cough is again a symptom. So remember, the pathology could be inflammatory, and you know that inflammation is seen by fever, pain, etc. But a chronic inflammation could have very minimal pain, minimal fever, but a lot many constitutional symptoms. Non-inflammatory pathology have nothing of this. Having known the microanatomy and the pathology, then only you start thinking about possible etiology. And if it was inflammatory, commonly it's an infection, but which could be bacterial, fungal, viral, parasitic, tuberculous, whatever. And if it was non-infective, inflammatory, then it's allergic or aspiration or maybe even a cardiac condition. Friends, etiology is a guesswork using adjective, acute, subacute, chronic, worsening, improving, or static, and a recurrent or episodic. Put these adjectives to cough, whether it is a recurrent or an episodic, it becomes almost a typical episodic cough as an asthmatic cough. Or if it is worsening, it means it's a fastly worsening disease. It must be an acute infection. So these are the components of diagnosis. Next slide, please. Now, let me give you a clinical approach to cough, and you are going to put all this approach to diagnose common 8 conditions that you and me may be often faced to see in our routine practice. So please look at this very carefully. When you have a child with a cough, your first question to the parents is it a predominant symptom? And if so, is it dry or wet? We have discussed this right on the first thing. The next question could be, is it having any time relation. For example, is it worse when you're lying down? Is it worse when you are exercising or running about? Any particular time, like the typical asthma is a nocturnal episodic cough. Nocturnal cough. The days are not so bad, but the nights are terrible. This gives you an idea that this cough could be an allergic or asthmatic cough. When it's a cough, remember, don't forget to ask the past history of a similar cough, because many types of coughs are recurrent problems. For example, a recurrent viral infection with a cough, or an asthma with a recurrent cough. So always ask whether this is the first episode of a cough or this has always been so in the past, which gives you surely some clue to a possible etiology. And then the next question is there any family history of allergy or atopy, or a personal history like an eczema, skin rash, or a running nose or a sinusitis, are all allergic manifestation. And in the presence of all this, the etiology of cough could also be allergy. But as we learned in the first clinical term in the second MBBS, always ask for onset, duration, and progress of cough. It often gives you a clue. For example, if it is an acute sudden onset, in few seconds, the child was all right and now starts coughing badly, I know it's some mechanical cause like an inhaled foreign body. Duration is important because most of the acute conditions last for a short time, maybe a week or two at the most. But something that lasts beyond that is possibly not a simple acute infection. Similarly, the progress, whether it has been worsening, static, recurrent, episodic, we talked about that. And then, of course, ask for many other symptoms along with cough, which may be cold, which means even an upper airway is involved, fever, breathlessness, chest pain, etc. Finally, when there are multiple symptoms, always inquire what has been the sequence of appearance and also disappearance. For example, it's not uncommon to see fever, cold, cough, but I want to know the sequence, which came first, which came later, and which disappeared first, which took long time to disappear. All this would make a difference in the ultimate clinical diagnosis. And having given these basic concepts, a concept of deciding anatomy, microanatomy, pathology, and then guess etiology, and the classical approach to a symptom of cough. Now let's go through 8 types of common conditions which you and me are likely to see in routine practice, and try to see how you can easily make out between these 8 conditions. Well, friend, there are too many conditions which cause cough, but if you know these 8 conditions well, I bet you have solved 90 to 95% of the problems in patients who come with cough. The remaining 5 or 10% are so difficult that most super specialists also may have to undertake a lot of investigation, and that's not the point of discussion in our seminar. So with this background, let's start discussing 8 cases, and you try to make out your own judgment and vote for it. The next slide, please. This is my first case. Note the history very carefully. This is a 2-year-old child who comes with high fever, cold, and cough for last 3 days. I told you, when you have more than one symptom, you want to ask for the sequence of appearance and disappearance. And you want to ask, what is the chief complaint? Look here now, fever came on first day, cold and cough followed on the next day, and the fever and cold disappeared by day 3, day 4, but the cough continued for almost 6 or 7 days. Well, all were predominant symptoms because the child was much uncomfortable with all 3 of them, and the parents said all 3 are predominant symptoms. But take a note of the sequence of events. Fever on day 1, cold and cough on day 2. But fever and cold disappearing by day 4, but the cough taking few more days to disappear. Now, with this kind of an symptomatology and the sequence, I want you to give a diagnosis, whether it is an acute bacterial infection, whether it's an acute viral infection, whether it is an acute bacterial sinusitis, or any one of the above is possible. Your time starts now. Fine. Let's see how all of you have reacted. Well, I think most of you have said it's an acute viral infection, but few have said that it could be any one of the two, whereas few people further have said, but nobody has called it sinusitis. Again, an excellent way of making me happy that majority of you felt that it must be a viral infection. Now, why did I say it's not a bacterial infection? For example, if it was a bacterial infection, the child would not have got so easily well in next 2 days. Again, a cold is rarely a bacterial infection unless it gets worse and becomes thick, mucopurulent, then it becomes almost sinusitis. Therefore, this is unlikely. A typical bacterial infection, it does not involve entire respiratory system. It either causes tonsillitis, where there is no running nose or there is no chest sign, or you have a pneumonia, where there is nothing in the throat or nothing in the nose. So bacterial infections are localized, whereas when you have a cold, cough, fever, something generalized, it's most likely a viral infection. But very few have said that it could be one of the three, but it's unlikely sinusitis nor a bacterial infection. But yes, most of you got well. Well, friends, this is learning exercise. Let me tell you that at the end of 55 years of practice and teaching, I still make mistakes. And when I make mistake, I have learned. And then I know that I should not make this mistake again. So don't worry. Let's see the next slide, please. Now, the next is my another case, again 2-year-old with high fever, cold cough. Again, parents felt all three are important for them. Now, look at this sequence of events. Fever on day 1, cold and cough on day 2. And fever disappeared and cold also disappeared by day 3. But the cough continued for 2 weeks. Make a difference between the first case and the second case. Both look alike, but in the first case, the cough also disappeared within 5-6 days, whereas in this child, the cough seems to continue for 2 weeks, though fever and cold have disappeared. Now see again whether this is one of the 4 that you feel is your possible diagnosis. Your time starts now. Let's see how now you're going to. Excellent, friends. Extremely fine. Okay. What you are all saying is that normally in a simple viral infection of a respiratory tract, the cold and fever disappear rather fast. Fever always disappears within 3-4 days. The cold often lasts for a short time, but the cough continues for a little longer time. But at the end of 5, 6, 7 days, everything is gone. But when the cough continues longer, almost for 2 weeks, and parents are worried, they ask you why doctor is not getting well. And your answer is, look, he's already got well because fever has disappeared, but his airways seem to be hyper-reacting. They are hyper-responsive. What does it mean? The airways react unnecessarily for a long time. Almost airways get angry for no reason. Some virus has gone in the airway and the anger lasts for a long time. This is called hyperreactive airway. This may be caused by a common viral infection or when it is caused by any allergen like a dust mite or molds or even the plants and pollens. We call it asthma. It is hyperreactive airway. Excellent. So you know that when the cough lasts long, what is important? Such a child is likely to have a repeated cough due to varieties of triggers, including a viral infection. You must preempt the parents here and communicate and counsel with them to say that, look, don't worry about this extension of cough, but please remember that if there's such a cough comes even without fever, I need to know what has triggered it. And this is called hyperreactive airway. Like, good. Let's go to the next case. And my next case is something a bit different. Okay. Now, this is a little older child, 4-year-old, who starts with fever, cold, and cough again for last 3 days. Now, look at the whole story now. The story starts with cold, followed by cough on day 2. And when did the fever came? Fever was mild and came on day 3 and quickly lasted for just 2 days and disappeared. But the cold and cough continued for 2 weeks. See the fun? Parents tell you fever, cold, and cough. First 2 children started with fever and the fever disappeared quickly. But the cough continued in the first child for a few days, but in the second child for a long time. This child does not start with fever, starts with cold and cough. And the fever is very mild. Oh, thoda badan garam lagta hai, fine. And that disappeared. But cold and cough continued for 2 weeks. Predominant symptom in this child is cough. So make a note. Predominant symptom is cough. Now you decide which of the 4 conditions you would vote for. Your time starts now. Oh, wonderful. See, now I am always convinced that in an interactive session, once I start giving you the problems and you start thinking, then I am sure that you know how to think and how to get an answer. In routine practice, and in most of you are so busy that you have no time to think. But friends, if you think, and thinking doesn't take time. Once you practice, you can think very fast. How right you are. Why are you not calling it as a hyperreactive airway? Yes, it is a hyperreactive airway, but not triggered by viral infection. Okay, why do you say that? Fever is very minimal and came much later. What is the lesson learned out of this? Majority of acute infections start with fever, and something where the fever comes a little later is either a subacute or chronic infection or totally a non-infective disease. Here, the fever hardly remained for a day or 2, and it was mild. So this was not a subacute or chronic infection, but this was a non-infective condition, and that makes it a multi-triggered allergic condition like an asthma coming. You would have asked for a past history, and this I might have said, yes, I have had some episodes of cough here and there, but good. I'm making these small differences in these cases for you to take a note. But I'm very happy majority of you have seen this difference. And with this now, Let's get to the next case. Okay. Again, something little different. Again, a 4-year-old child with high fever, followed 2 days later by mild breathlessness and a mild cough. Take a note. Starts with fever, and first 2 days there is only fever. Thereafter, very mild breathlessness and a mild cough. Breathlessness was relieved by day 4 by treatment. Fever disappeared by day 6, but the cough got worse, but disappeared after another few days. So look at the whole sequence. What is the predominant symptom in this child? Not cough, but fever. Now take a note of this sequence of events and now try to diagnose between bronchiolitis, bacterial pneumonia, tuberculosis, or hyperreactive airway triggered by viral infection. Your time starts now. Most of you called it as an acute bronchiolitis. Few of you called it a bacterial pneumonia. Nobody called it tuberculosis, and few called it now. Now, friends, take a note of that. Acute bronchiolitis is a viral infection where fever lasts for a very short time and breathlessness comes pretty early, like in this child, it come on day 3, and cough is mild. So you're right. You thought breathlessness and cough, but I said in bronchiolitis, breathlessness more than cough. Here, both had mild breathlessness and cough. Another thing is, this child's fever continued for 5 days. In acute bronchiolitis, fever being due to viral infection hardly lasts for a day or two. Breathlessness, if treated properly, also lasts for 1 or 2. And the cough is not a feature. Cough is mild. But look at this child. This child had fever lasting for 5 days, unusual for a viral infection. Second, the breathlessness and the cough continued longer period. And to that extent, this is typically what happens in a bacterial pneumonia. Why does the cough come up later, worsening? This child did start with a mild cough and a mild breathlessness, but moment the antibiotics were given, the first symptom to disappear was breathlessness. And the next symptom to disappear was fever. But the cough worsened. For the parents, the child is still worsening. No, but for you, fever has disappeared, so infection has been well controlled, breathlessness has gone, which means the lung function has improved. But why has the cough worsened? Because the damage that has occurred in the lung parenchyma has to now get out of the airway, either absorbed within or expectorated. And at that time, the cough seems to get worse. But over the next few days, even that damage disappears, is controlled. Friends, what we have learned is what starts with fever is infection. You are right. But the fever lasting for a longer time, unlike in a bronchiolitis, just 1 or 2 days, and then cough continuing longer, is a typical story of a bacterial pneumonia. And I want you to understand that sometimes, even where your treatment is right and the disease is well under control, one of the symptoms keep on worsening. And if some symptoms worsen, then you know that parents feel the child has got worse, but you need to communicate and counsel them correctly to say that worsening cough is a sign of improvement, that the nature is taking care of damage, right? Let's get to the next slide. So we have seen so far 4 of them. Let's get to a little older child, 8-year-old child. who starts with high fever, take a note again, nasal discharge, and cough for 4 days. Fever and cough disappeared by day 5. Take a note, took a long time, took 5 days to get better, but the nasal discharge continued mucopurulent for good 2 weeks. See the fun again. High fever, nasal discharge, cough, all starting together, and you have day 4, day 5 getting better with fever and cough, but the nasal discharge continues for more than 2 weeks and it is getting mucopurulent. Now, when you ask for a past history, yes, there is episodes of allergy in the child and also atopy in the family. So you have an allergic background at this child. Now you have to choose between the 4 conditions that I have put down, and your time starts now. Excellent. I think all of you got it so right. How did you analyze it? High fever, so infection. Fever lasting for about 4 or 5 days, unlikely viral. I don't mean that viral infection can't go on for a long time with fever, but we are discussing the common things first. So generally, most of the viral infection, the fever disappears by day 2, day 3, day 4 at the most. Rarely day 4, almost never thereafter. This child has high fever for 5 days. Okay, cold and cough. So we knew that he had an upper respiratory infection, largely cold. And then the fever and cough disappeared, but the cold continued long. And why did that happen? Because there was an allergic element, like we saw a hyperreactive airway triggered by viral infection in our second case. This is something similar. There is an allergic background. On the top of it, you got a bacterial infection. Why bacterial? Because the fever lasted for a long time. And why bacterial? Mucopurulent discharge, purulent, not watery discharge like a viral infection. And therefore, most of you are right. This child would need an antibiotic, but you will have to counsel the parents to say, look, after your child is all right, I need to worry about the chronic allergic rhinosinusitis, for which your child may need some long-term treatment, and you counsel them at this stage, because once they come back again and again, you have already told them that, yes, this might recur again, right? But good. Let's see another case. Okay. My next case is again an older child. He's an 8-year-old child with history of fever for 2 weeks. Now see the duration of fever. Mild cough. Fever was moderate, but persistent for 2 weeks. Naturally, predominant symptom was fever. Take a note that this was a mild cough. So you decide where must be the microanatomy, whether airways, whether lung, whether pleural, interstitium, and fever lasting for 2 weeks. Take a note of duration of fever. With this, you have 4 possibilities, whether it's a bacterial pneumonia, whether it's a viral infection, whether it is tuberculosis, or for all that you know, it could be myocarditis. Your time starts now. Excellent. Okay. Majority of you have said tuberculosis, though few have also considered a bacterial pneumonia. Now, friends, let's think a little more about these possibilities. This child is running fever for 2 weeks, Had it been a bacterial pneumonia, first thing, breathlessness would have been a symptom. This child is not breathless. Therefore, this is a subacute or a chronic infection coming. Again, the fever has never been high. It has been moderate. And if a bacterial pneumonia continues to run fever for 2 weeks, it would be almost called as a complicated pneumonia, which means either it has developed an empyema, or it has developed a septic shock, or it has been resistant to antibiotic use, but some complications have occurred, which means the child would have got worse. What did I mention on the case? Child had a persistent fever, moderate, no complication, which told you that this was a chronic infection. Acute infection would have had a complication coming up or would have got well. But acute bacterial pneumonia without breathlessness and going on for a long time is therefore not likely. And acute myocarditis would have come with breathlessness more than any just fever by itself. After all, when a myocardium is involved, the breathlessness is a symptom. As this child did not get breathless, this is neither pneumonia nor acute myocarditis. And the answer was right, tuberculosis. Let's get to the last but one case. And that is my next case of again an 8-year-old child. This child has cough for last 2 months. Make the note of a duration of this cough. He has tried all kinds of drugs. Okay, there has been no improvement at all. He has no fever. He is not breathless. His sleep is also not disturbed. Okay, now there is no past history of cough, no past history of allergy in the family or in the child. So this is a child who has 2 months of cough, but there is no other symptom whatsoever. Now you decide whether between tuberculosis, asthma, inhaled foreign body, or it's a habit cough. Your time starts now. Let's see how all of you, excellent, oh, perfect. Okay, now few have said it could be inhaled foreign body. Yes. Inhaled foreign body, the typical story would have been a hyperacute onset of cough. Okay, again, this child is a little elderly child, and he would have given that history of a sudden choking and a sudden starting of a cough. That was missing. Now, why did most of you call it a habit cough? Because it was neither worsening nor improving, remaining same, but it even did not disturb sleep. Majority of the conditions causing cough disturb sleep the most, besides disturbing general activity, energy, appetite, weight. This child did not have any of the problem. He was just coughing. This is a habit cough. It's not extremely rare. And habit cough comes out of some stress. And I recall seeing children with habit cough who continuously cough non-stop. But when I put them on the couch and I tell them, now you will have to stop coughing because I can't examine you otherwise and can't make out what you are. And most of them obliged by trying to stop their cough. Okay, which is the test? This is the diagnosis of exclusion, but I'm happy you all got well. Let's see the last case. And this is a 2-year-old child. Again, a small one. Take a note. History of cough for 4 months. He's also having cough for a long time. He has no fever, no breathlessness. There is no atopy in the family. But when I ask a direct question, how did the cough start? Oh, they said one fine day, all of a sudden, when he was playing, he started coughing badly. I'm sure, friends, you will diagnose this very, very well. You have 4 conditions to choose from. Your time starts now. I'm sure that's right. Excellent. Okay. The point that this case taught us was that always ask for origin, duration, progress. We learned that right to begin with in our clinical terms. When something happens suddenly, acutely, in seconds, it's a mechanical cause. And which other mechanical cause can cause cough or breathlessness? Inhale foreign body, usually cough, rarely breathless. Breathlessness in a foreign body is only if it is stuck up at the trachea, and then it's an acute emergency. But a sudden development of a pneumothorax can cause breathlessness. A sudden pulmonary embolism can cause breathlessness. So sudden conditions are mechanical or vascular. And you are right, this was inhaled foreign body. Friends, we will now discuss a bit about investigation in a child with a cough. And my next slide talks about investigations. The next slide, please. Now, how useful is a CBC? To my mind, a bedside diagnosis is so vital that if you have diagnosed pneumonia, whether you have how much of WBC count or polymorph, yes, you are generally expecting a neutrophilic leukocytosis. What about eosinophilia? Oh, eosinophilia is not a diagnosis of asthma. It could be any allergy, including a worm infestation. Okay. And absence of all these typical CBC does not rule out anything at all. And therefore, don't jump to give diethyl carbamazine moment you see eosinophils. Oh, it's not almost never required. What about chest X-ray? I think the golden rule is if your patient is having a very severe cough, then a chest X-ray is unlikely to give you a diagnosis because a chest X-ray depicts the lung parenchyma or a pleura much better than the airway or the interstitium. And all that you might see is a bronchovascular marking or some small haziness called pneumonitis, but that does not give you any clue at all. So, friends, you must have seen that many times parents and patients ask you, well, I'm coughing so badly, but my chest X-ray is normal. My CBC is normal. Well, that is because the airway is not much visualized by chest X-ray. The only exception for asking for a chest X-ray in an airway disease is an inhaled foreign body. But that we have seen already clinically discernible because of a hyperacute sudden onset. What about ultrasonography? Today, USG is a benchmark for a pleural effusion. If you're suspecting a pleural effusion, ultrasound is an excellent tool, even better than a chest X-ray. And today, even a good sonologist feels pneumonia can be better picked up by even an ultrasound. But yes, chest X-ray can pick up a pneumonia very well. What about CT scan? Friends, rarely required. Don't forget, CT scan gives you a lot of radiation exposure, and that could be a future trigger for even cancer or malignancy. So don't expose people to CT scans for a very small, trivial reason. There has to be a strong reason for a CT scan, and I feel CT scan is rarely required in pediatric respiratory problems. Well, if it is required, it's only for those small few percentage of patients where once all the common conditions are ruled out, you may ask a specialist to decide what to do. Therefore, a generalist like you and me will rarely need a CT scan. What about pulmonary function test? Do you need to diagnose asthma? No. Asthma is a clinical diagnosis. And don't forget that pulmonary function tests are very difficult to carry out by a child, especially a younger child than 6 or 8 years of age, and even the older children and adults find it difficult to give a good cooperation for a pulmonary function test, because in a typical spirometry, you have to inhale deeply, then exhale again with force, inhale again. All this is not easy, and therefore a pulmonary function tests are rarely required in pediatric practice, and I'm sure in adult practice, to differentiate between COPD and an obstructive airway disease, you may need that. But the problem of a pulmonary function test is a good cooperation by the patient. What about pulse oximetry? Pulse oximetry is becoming a clinical bedside part of a clinical examination, because if the pulse oximetry shows less than 95%, you start worrying whether the child is deteriorating in lung function. Well, having discussed this, let me just dwell a little on treatment part. And I think when it's a treatment that we are discussing, when specific treatment is required, like for an acute infection or for tuberculosis or for inhaled foreign body to take out a foreign body, whatever, yes, we know that. But what about the symptomatic relief to a patient with cough? We have so many cough syrups. I want you to interact with me now on the next slide. And the next slide, please. I want you to tell me which cough syrups you use, one with a cough suppressant, one that is expectorant, you add a mucolytic, you have an antihistamine, you use a bronchodilator, or best is you use a combination cocktail. Your time starts now. Well, this was a tricky question, I'm sure. Okay, many use mucolytics, few use expectorants, further few use suppressant, and some use cocktail and some use bronchodilator. Friends, I wanted we to understand, oh, there is some expectorants and all that. Fine, which means that every part of what I have asked has some reason to be used. And my next slide, please. We try to justify where we use all this. Cough suppressants are only for a dry cough and use with caution, because quite a few of them have a lot of side effects. And the codeine is the best cough syrup suppressant, but a very, very highly having side effects. So don't use that. But options are dextromethorphan or a falcoidine, and use it on a SOS basis. That means only when that cough is causing a terrible trouble, generally at the bedside. And I think local demulcent is safe. Just putting some lozenge in the mouth or even a sugar cube is good enough to kind of suppress a dry cough. Expectorants are useful only in children who have a lot of ability to expectorate. And small children don't have ability to expectorate, but a bigger child can expectorate. You might use a drug like guaifenesin. Mucolytics are often used because they can kind of liquefy the mucus. Again, useful for little older children with wet cough. You can choose between bromhexin, ambroxol, rarely acetylcysteine, especially in children with bronchiectasis, cystic fibrosis, or a COPD. Yes, they are very useful. Antihistamines are usually useless in allergic conditions causing cough. Like in asthma, there is no role of antihistamine at all. But antihistamine is a mild sedative, and sometimes used with caution at bedtime can make the child sleep, and in sleep, he does not feel his irritation that causes cough, and therefore he is cough-free, and at least you offer him a sleep relief. Well, when it is a bronchodilator, you reserve it only for a bronchospasm. And many children for an acute viral infection also may have a little bronchospasm. You might use that. inhaled drugs are preferred over oral drugs because most of the bronchodilators cause a tachycardia and even cerebral irritation. Having said this, let me show you the last slide to summarize what I had to say today. I have told you how the detailed history helps a provisional diagnosis. Follow the simple standard protocol of questioning. Diagnosis is often clinical. Investigations are required only in specific condition, but counsel the parent. That is very important. Counsel them about possibility of recurrent cough, counseling them about how cough remedies are often not very, very useful, and use also traditional cough remedies like honey, warm water, propped up position, a good ventilated room, avoid very light clothes, use light clothes, not avoid, sorry, use light clothes so that the breathing is fine. Well, I come to the end of this session and hand over it to Dr. Agarwal. Dr. Agarwal, please.
Yeah. Thank you, Dr. Amdekar. It was an excellent interactive session. I think there are glitches which we faced in interaction last time. They were all removed this time, and I hope viewers must have enjoyed it. And a lot of questions have been coming. So can I take few questions, Dr. Amdekar?
Yes, please.
So one question is very interesting. Can we make out something from the color of the sputum, whether yellow or white? Does it indicate anything towards diagnosis?
Yes, I think as I told you that mucopurulent sputum or a nasal discharge, purulent, and make a distinct small difference between yellow color and green color. Green color is always a bacterial infection. A yellow color may be a gray area. It could be non-infective, it could be viral infection, or it could also be a bacterial infection. So that yellow color is a little gray area, but a white color, especially watery, is not a bacterial infection. So I think that is what is important. When it is a bit thick, mucus, and it's white, it's often an inflammatory, non-infective condition, like an asthma, for example. They bring out, after a lot of cough, a little whitish mucoid secretion. So your question is valid, yes. It gives you a difference.
So this question was asked by Dr. Safat from Raebareli. So next question from Dr. Elizabeth from Kerala. Can we treat hyperreactive airway disease by bronchodilators?
Yes, but the bronchodilators, as I said, have a problem, especially in younger children and in age 4, 5, 6 years. Every bronchodilator causes a tachycardia and a cerebral irritation, which makes them cough more. So do give a trial, but again, give a drug at a specific time when that bronchospasm is worrying the child. For example, you have diagnosed a hyperreactive airway, right? But if he is reasonably comfortable, leave him without a bronchodilator. But if you find the wrong guy, if the cough is spasmodic, yes, use a bronchodilator. But lastly, if you need to use a bronchodilator for a longer period, then it is better you use an inhaled bronchodilator because that's a small amount and that has much less toxicity and that is much safe for a prolonged use. But yes, you are right. But if it's a viral infection induced hyperreactive airway, it disappears very quickly, but use it SOS only if that kind of a bronchospastic cough is troubling the patient, right? Yeah.
So next question comes from Dr. Bindu from Mumbai. What is the cause of recurrent or persistent cough?
Yes, a good question. First thing, you must differentiate between a recurrent cough and a persistent cough. What is the difference? A recurrent cough episodes, the patient is absolutely normal in between cough episodes. For example, somebody gets a viral infection and a cough, that disappears. After 4 weeks, he gets another episode and he gets the third episode. But in between those episodes, he is absolutely normal. But a persistent problem is that the cough may reduce, cough may be less, But there are never few days when the child is all right. There could be few hours when the child may be without cough. But the cough is always there sometime or the other through 24 hours. That is persistent. If it is a persistent infection, even if the fever disappears for a while and maybe after 12 hours come again, if it's persistent, then the patient is sick in between those episodes. He is in distress in between two episodes. He is not normal in between two episodes. So first differentiate between recurrent and persistent. Persistent is a continuous disease. Like if a cough is persistent for 2 weeks, it's either a hyperreactive airway triggered by that, but then should disappear after that. But if it continues for 4 or 6 weeks, you are either a whooping cough, pertussis, or you have a tuberculosis, which means persistent disease. And if it's a recurrent problem, then it causes a recurrent viral infection or a recurrent allergic condition. Two most common conditions which cause recurrent cough, but in between episodes of cough, the child is absolutely all right.
I think this is more than an hour of an interaction. So
that's right.
Do we take just one more question, last question, and then rest of the questions we may cover in the GP clinics session summary? So last question is when to prescribe antibiotics in a case of cough?
I think antibiotic is to be prescribed only in children with cough who start with fever. That's number one. We are talking about acute problem. I'm not talking about chronic problem like tuberculosis or cystic fibrosis or whatever. But if somebody starts acutely with fever and cough may come later, cough may be mild, cough may be severe, whatever. But starts with fever, note that this is infection and make a difference between viral and bacterial infection. How will you make a difference? A viral infection has cold and cough. A bacterial infection causing cough rarely has a cold. They have often cough. Then viral infection, the fever disappears by day 3, day 4, starts getting better by day 3 and gets better by day 4. And viral infection is more common in younger age group and is often have a family history of a similar infection. Whereas the bacterial infection are more localized. If they have a dry cough, it's only pharyngitis, nose is not running. If they have a wet cough, it's a pneumonia. Again, there is no throat problem or a cold problem. And there are no other members in the family having a similar disease. And the fever lasts for a long time. So, no fever to begin with, no antibiotic. Fever to begin with, difference between bacterial and viral. If you are not sure and the child is not breathless, wait for a day or two. Counsel the parent, tell them the importance of not using antibiotic irrationally. It's dangerous to their own self, it's dangerous to the community and to all of us. If you explain confidently, the parents know you are so confident, they have full faith in you. They wait for a day, and the next day the fever disappears. You know that infection was viral. I think be confident with what I've said. You will enjoy the rationality of thinking. Back to Dr. Agarwal.
So it's almost more than an hour of an interaction, very excellent interaction. And now towards coming close to the session, one observation I would like to make that many people are answering to the questions in the chat box. I think they need to look at the pop-up which is coming below the chat box. Just make the scroll down your screen and then a pop-up is coming. So I think next time people should take care of it. And instead of answering the questions in the chat box, you have to just click on the choices, which is coming below the chat box. So as we are coming close to the end of the session today, on behalf of GP Clinics and docislive.com, our interactive digital platform, I thank you all the doctors who have attended this session. It is quite overwhelming to see such a huge attendance in this second session as well as was there in the last session. Thank you all of you once again. It must have been a memorable learning session for all of you, as may be the future ones as well. I also thank Dr. YK Amdekar sir for sparing his valuable time for all of us. Listening to you has always been a learning feat. I'm sure everyone would agree. Please note the date for the next webinar. It will be 21st of August, 2022, Sunday, 11 a.m., same time. The topic would be diarrhea when solid waste becomes liquid. So please join our WhatsApp group, dockieslive.com, to get regular updates about the series and future webinars and all our digital activities we plan ahead. Lastly, I would request you to please give your valuable feedback for us to improve to serve you better in subsequent webinars. Thank you once again to all of you. Good day.
Thank you. Good day to all of you.
And thank you to our digital team as well, Dinesh and others.